Wednesday, September 11th at 6 o'clock, 2024. The Program and Budget Committee. Please rise for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Now I'm reading a mission statement.
Here.
Yes, we have a quorum. Thank you.
Macomb County Community Mental Health, guided by the values, strengths, and informed choices of people we serve, provides quality services which promote recovery, community participation, self-sufficiency, and independence.
Thank you. And since today is September 11th, it's not on the agenda, but just a moment of silence for all the ones. Thank you. Item 3, adoption of the agenda. Do we have a motion? Support. Motion by Donna, support by Mark. All in favor?
Aye.
Motion passes. Item 4, hearing the public. Is there anyone from the public looking to speak to this board? Okay. Thank you. Item 5A, request to approve MRS agreement 3313, interagency cash transfer agreement, $4,000. This is approved by legal. Nicole or Helen? Yeah, we would like a motion. Support. Okay, motion by Linda, support by Phil. Hi.
So we have a long-standing relationship with Michigan Rehabilitation Services where they provide assessments and they provide vocational services to our clients. So we are just looking to renew that agreement with them with this interagency.
Thank you. And is the microphone on? I had a little bit of trouble hearing.
Push it real hard.
Okay, well, that's fine. Does anyone have it? Thank you. Does anyone have any questions? Okay, well, thank you very much. All in favor signify by saying aye.
Aye.
All opposed? Motion passes. Item 5B, request to approve MRS agreement 336 interagency cash transfer for $134,360.
Move to approve. Support.
Motion by Linda, support by Lori. Helen.
Yes.
There.
Hi. Yep. So similar to the substance use one that was just presented, there's also a cash match with mental health. And so again, this allows MRS to draw down quite a bit of federal dollars if we participate in this agreement with them. They then use that money specifically to target unique services for the individuals that we serve. And there's a brief summary in the board action request here, letting you know about the past year's information. And then annually they'll send a report to us after the end of the fiscal. They share our fiscal for after September, and they'll give us the annual report of how many we're serving out.
Thank you, Helen. Does anyone have any questions? Nick.
We get a copy of the most recent report.
I have one, and yep, I can send it on to Tracy.
Does anyone else have any questions? Okay, we have a motion. All in favor signify by saying aye.
Aye.
Aye. All opposed? Motion carries. Item 5C, request to approve MDHHS agreement with CMH for eligibility specialist position, $74,900. And this is Tony.
Move to approve.
And
Support.
motion by Linda and support Lori. Thank you. Hi, Tony.
All right, this is a renewal. We've been fortunate actually to have the same individual contract from the state. We're going to this will be the third year, which is good because she provides support to about cases. Her focus is on eligibility, spend down to be a point of contact for our consumers and our liaison with the state. So this is just a renewal, $750 increase from what we currently are paying. And unless there are any questions, pretty straightforward.
Anyone have any questions? Well, we have a motion. All in favor signify by saying aye.
Aye.
All opposed? Motion carries. Thank you, Tony. The next item is item 5D, request to approve the MISD contracted services, school-based therapist, $269,000, and this is approved by legal. Is there a motion?
So moved. Support.
Motion by Dana and support by Donna. And Tracy.
This is also an agreement that we've had for the last couple of years. Just a reminder, we currently have 3 staff, one in the elementary school, one in the middle school, and one in the high school. And the school district pays their wages, so here's that's what the agreement is saying. They're going to pay the wages and benefits of those individuals so they can be housed in their locations. They are paying wages, benefits, and fringe associated with it for 9 months. So then we're covering the other 3 because obviously those individuals are still with us. And they provide direct services, both our services and what makes sense from the school district's perspective.
Linda.
Is a big part of it prevention in the schools?
This one I should have been more specific. This is specifically assisting individuals who might have mental illness, SED, and or IDD, so a child who might be experiencing that, and it's specifically at the 3 schools in the school district, and forgive me, the names, they're in the write-up, I just don't remember the top of my head, that specialize in that particular area.
Donna.
Yeah, I did school-based, and that was my first hire. I was at the Newry, and I was at Rockland. As,
Those are the 2.
yeah, and the other was
Yes.
Maple Lane.
Thank you.
During the summer, when the school is out, do they come into the outpatient clinics, or are they seeing some of the students in their homes? I know when I was in the school-based, we used to go into the homes and see some of the students visit them in the homes. So I'm wondering which one they're doing, or are they doing both?
Yeah, and I would probably give you a general answer, but I happen to have 2 people from children sitting in the audience because they're presenting later. So they are going to probably give you the most. Of course you have to come over. That's happening.
I'm sorry. I asked that.
No, it's a good question. She would do a much more thorough job of answering that question.
So you're wondering what they like
In the summer, are they staying in the outpatient clinics and seeing like just generalized people, or are they going and seeing some of the students that they saw in their homes?
They can do both. Yeah, so they're seeing some of the individuals who needed, the therapy continued during the summer months. They would see them. They also this past summer helped out with our mobile crisis unit. Wherever the need has been is what they've done. So they've done assessments as well, bringing people in for intakes and things like that.
Thank you.
Any other questions? Thank you. All in favor, vote by saying aye.
Aye.
All opposed? Motion carries. Item 5E, request to approve CBH 2024 Amendment 3. It's approved by legal. Is there a motion?
So moved.
Support.
Motion by Dana, support by Linda, and either Jeff and Helen.
So this is one of the grants that we've had going for the full fiscal year. The state opened up the grants so that we can make a change. So in this one, our veteran navigator went from a contract position to a county position. So it just allowed us to open up the grant so that we could realign on the budget page the information the way the state asked us to report that information from a contract line to a staffing line. And so that was the only change that we needed to make on this one. They also opened up our drop-in center by mistake. So it showed as something needing to sign to get a new grant, but there's no changes to that grant at all.
Okay. Any questions? All in favor, say aye.
Aye.
Aye. All opposed? Motion passes. Item 5F, request to approve CBH 2025 contract. Is there a motion?
So moved.
Dana,
Support.
support Lori, and this is also Helen.
Yeah, so this one here, some of you may recall that we provide opiate health home services in our current contract under the state for substance use. So coming for FY25, the state offered for us to be able to provide behavioral health home services. And so this would allow us to now expand the similar type model for particular mental health diagnoses. And so we will be working with 3 contracted agency providers and one of our direct clinics to start the roll-off with this in October. And so this, again, is one of those wraparound, feel-like kind of services. It's not, the wraparound service we do, but it's where you have a nurse care manager and you have peer recovery supports that help as part of the team that provides a lot of the social determinants of health needs for individuals. And so it's really to kind of take a more intensive look at a case and provide services to help that person in their recovery journey.
Thank you. Anyone have any questions? Okay, all in favor say aye.
Aye.
All opposed? Motion carries. Item 5G, request to approve CCPH 2025. Is there a motion?
So moved.
Support.
Motion by Dana, support by Lori. And this is also Helen. What's wrong?
They all start to sound the same.
They do.
Was it Donna's support?
No, it was Linda.
I'm sorry.
Lisa.
I didn't hear it. I'm sorry. Okay, motion by Linda, support by Donna. Motion by Lori. Okay. All right, sorry.
We'll serenade. Yeah, that'll help you.
Okay.
So for this, we have our current fiscal year 24 specialty grants for mental health funding. And this for 25 will continue with the same grant areas. And so this is just asking the permission to go ahead and accept those funds for the new fiscal year and continue those grants that are currently underway.
Is there a motion? Is there any questions? All right, all in favor say aye.
Aye.
All opposed? Motion carries. Thank you, Helen. Item 5H, request to approve Jefferson Wells SOW billing verification audits. Is there a motion?
So moved down.
Motion by Donna, support by Laura. Thank you. And Christina and Tony. Hi.
So this is for the current Medicaid verification audit that's happening. You may recall that we do this audit annually, but the providers are audited biannually, so the different groups go every other year. This cost is for both the mental health side and the SUD side of the not to exceed amount. Tony did validate, look at the statement of work, and felt that it was in comparison with what we did last year.
Actually, again, it's actually lower than last year. One of the things we were able to do this year is look partner with our informatics department, and one of the main things is to provide a claims file. And by doing the work collaboratively with our informatics department, we were able to give Jefferson Wells a much cleaner file, which reduced the hours, which reduced our cost.
Any questions? Nick?
We apparently used Jefferson Wells before. How many years have we been using this particular considered periodically?
I would have to go back and give you the exact amount of years, so I can give that to Tracy to give to you. It's been many years, probably at least 15 plus years. I don't know if others remember. But we do RFP and I do it every 3 years.
Any other questions? Tony, I just have a quick question. Roughly, if you know off the top of your head, if you don't, it's okay. How much did we spend last year on this?
We probably would have been right around 7,000 more than what we're proposing.
Okay. Even with all the increased costs, we're still under something. All right. We have a motion. All in favor say aye.
Aye.
All right, motion passes. Thank you. The next motion is request to approve an SOW amendment from Logigate contract for $28,500 $2,500. This was approved by legal. Is there a motion?
So moved.
Support, Lord.
Phil and Lori, thank you. And Ken, is it Logi or Logi?
They're supposed to be seeing there, that's probably on me.
Logi? Yeah, what a trick.
Yes, it is Lodgegate. As you might recall, we've engaged with Lodgegate not only for a policy workflow and approval, but we've also, the part that I've been working on is the contracting workflow and the approval, trying to have those be similar functionalities. As we were working through the workflows, we thought that the integrated Lodgegate approval function for contracts would be functional. We had subsequent discussions and we felt that it would be better not only for us and everyone using this, including our external providers and vendors, to have a DocuSign feature in there that would route through, it would go out, pick up the signatures, bring the document back in, and it would continue on its way ultimately to a repository that we don't currently have, that everyone that should could see all of our contracts and things. So this work is for Lodgegate for some extra hours to build that DocuSign functionality. That's $21,000 of it is a one-time cost, and the remaining $7,500 will be our ongoing annual DocuSign licensing fee that we have to use that. And I think we'll have to come back later once we have some other numbers, but there's an ongoing, I think, per signature fee that we'll have to evaluate as well. But those are the 2 components of that.
Any questions for Ken?
Did you have a concern that that you thought the DocuSign functionality was in the original contract, so that this extra $28,000 is making it more expensive than?
It is, and we're pretty far along in the process at this point, so we have admittedly learned some things as we've gone through it, and as we continue to build it. So it wasn't anticipated at first, but ultimately I think it will make it better system for us.
Ken, why do we have to pay an upfront cost on this one? It's not like DocuSign that they can do.
I mean, they have their costs. It's kind of like another subscription or anything that you would have. And I think they have, this is paying, I think they call it the interface that they have to join the two systems. Sorry. Some of my IT friends in the back speak to it better than I did. But
yeah, I could flesh that out with more detail, but you're doing just fine.
All right.
Watchtowers, that's all.
Yeah, so that's what's going to happen with that.
Thank you. Any
Quick question. Ken, you said after a certain amount of signatures, they start to charge per signature. Is that what you said?
Yep, I think per agreement.
Because I was going to say, how can we anticipate annually how many we sign and what that cost could be?
I don't think it's going to be significant as part of it. I think we have 350 agreements that ballpark.
Agreements makes me a lot more comfortable.
Right.
I start to follow us.
I think ultimately that cost will be minimal. But
Thank you, Mr. Chairman.
Any other questions? All right, we have a motion, and all in favor say aye.
Aye.
Thank you, Ken. Motion carries. Item 5J, request to approve the purchase of 600 non-violent crisis de-escalation manuals for $17,394. Is there a motion?
Support.
Motion by Mark, support by Linda.
I don't see Laura.
Stephanie.
Oh, there you go.
Yes.
Looking right past you, Jeff.
Right. No, okay, so I told Laura I already had to be here today for that, so I told her this. I'm very familiar with the CPI booklets. So the reason why we have to have individual CPI booklets for every single student is because their card and therefore the registration with non-violent CPI company is linked to like basically a serial number printed on that card that is located in each individual book. That's what we need to have in the book for every student. Plus, it's nice for that student to be able to take that with them
and refresh if, some type of event happens where they need to, stay up to date. The nice thing about asking for the large number of books now is that would give us the request for this year, calendar year, and then potentially through all of next year. Is there any questions on? And this is a biannual training. Yes, Mark?
Another important thing is the test in the back of the book.
The test is in the back of the book, yes.
All right, any other questions? All in favor say aye.
Aye.
Motion carries. Thank you. Item 5L, 5K, request to approve mental health matters 2025 planning contracts. Is there a motion?
So moved, Dana.
Support, Lori.
Dana and Linda.
Yeah.
I was looking. All right, Tracy.
So as you guys know, this will be our third year if approved to do our Mental Health Matters Awards. The request is for you to approve an expense up to, not to exceed $35,000. The majority, I think in the bar, you'll see they walk you through some generalized expenses. The majority of the cost is actually the facility and food, of course. But we planned on using the same kind of, the same location. We did tentatively see if it was available, and it is. The MC is also tentatively available. So we kind of tentatively secured on your approval the third week in May, and it's a Thursday. That's been trying to be like a pattern of some sort. So I'm happy to answer any questions. We did not add any additional expenses. We did the same as far as photographer, videographer that we did this year.
Great. Are there any questions? We have a date.
And forgive me if my camera sits, the third week in May. And I'll send it out to you. We're going to send a save the date. We're going to do this first. And
Right.
then
Okay.
save the date.
Awesome. Thank you. Any other questions? All right, all in favor say aye.
Aye.
All opposed? Motion carries. Item 5L, request to approve the purchase of marketing materials not to exceed $11,000. Is there a motion?
So moved.
Motion by Lori,
Support, Donna.
support by Donna. And this is also Tracy.
This you'll see in the bar. It explains in a little bit more detail, but essentially is for the purchase of some charging stations and a few other items for marketing that we would distribute when we go to events for the staff to be when they're out in public to have branded materials. The other thing you'll see in there is name badges, just as a heads up. We are hoping to order you all very fancy placards. Well, it's actually on Lori. Lori has attended events and she was so resourceful. She used her Mental Health Matters, which was great and it looked good. But we thought if you want an official name badge of some sort, we also wanted to order for leadership, so when we went to places, just to make us look more official. So that's what the items that you're approving for your consideration.
Great. Any questions? All right, all in favor say aye.
Aye.
Motion carries. Thank you, Tracy. Item M, request to approve PIHP edited 2024-2025 contract pending, I say pending, legal approval. Is there a motion?
Support.
Motion by Mark, support by Donna. Richard.
I'm going to give the intro, and then Richard's going to jump in and answer any questions. I apologize. I forgot to give these to Sandy to hand out, but I'm going to use this as a kind of a reference point for you. And I'm not even right next to this. You could kind of put that down. So once you get this in front of you, you have kind of a chart. Because today what you're considering, and you guys all have the recommended edited and straight-through language of our PIHP contract that begins October 1st. The reason why I gave you this document is we're just going to walk you through two things. What are our three concerns? And then when we talk about the three concerns, is this is an evolving situation. So as of yesterday, I think I communicated we do have some new proposed language. So we're going to start with our first concern, which is the law school settlement. So as of yesterday, midday, the newest proposed language, which just to be clear, in your board package, it will not match because on the WASCO we crossed through, so I'm going to read you what they're proposing now, and then we're going to move on to the next one. So the current new language would state, contractor must comply with all terms and conditions of the WASCO agreement Once it's approved and all contingencies have been met, MDHHS is tracking rate implications, and once final settlement is reached, will include funding in PHP rates. The GF appropriations in the FY25 budget can be adjusted. MDHH expects contractors to amend their subcontracts once this settlement is finalized. Just as a friendly reminder, the law school settlement is in relationship to the class action that the state of Michigan is trying to settle with a group of individuals. It does not go back to court until December, so it is not finalized. So obviously that is our concern, is to be held accountable or to agree to even the language that I just read to you for something that is not finalized. This language is better than the ones that you've seen in the past, but we still have concerns about it. And Richard, you're welcome to add any feedback on the law school if you'd like.
Yeah, I mean, the big thing with law school is, of course, the trickle-down effect on the rest of the provider network, right, in terms of other individuals that need to have resources for. And my concern is that, in part, what the department is wanting to do is to show the judge that, well, we already have contract language in place that kind of supports moving forward with the settlement, even though as a PIP group, we do not support the settlement. So sending the message, sign it as is versus, delaying and waiting for settlement.
So our request, so what you're considering now, just on this language, is currently we need another cross through. We're exploring just this option to also cross through once we receive it. I'm saying once we receive it because I'm communicating with you from an email that was sent yesterday. So technically, until we receive the official contract with this language, would be when we could say we agree or disagree with that.
Nick, do you have a question?
First, I want to commend Tracy for all the work they've done on this contract. One of the other concerns I have with both of us the C language is that we don't know what the court has approved law school yet. CCDHC is an open-ended funding commitment on our behalf. I don't like signing blank checks. I'd like to know what it is we're going to spend so that we can be sure that it fits within this budget. And I think the state should realize that. I also think it's important, and it runs contrary to what we've been trying to do on the reserve fund, which has its own concerns, and we discussed it here before. And so I think it's important that we continue to negotiate on this point. I note that we're only sending it to the full board with the recommendation that we continue to negotiate, basically, and try to get them to come to some sort of agreement. But one of the areas that over the years I've expressed concern about is the rate-making process. So do we have a rate in this contract yet, or do we have to do something
Nick, is your microphone on there?
Yeah. Okay. They don't answer.
We can't hear you.
I'm sorry. Do we have a rate?
Not today. Hopefully we'll have rates, we've been told, on September 16th, so prior to the full board meeting.
Because one of the problems is we've been asked in the past to sign a contract that didn't tell us what the rate was. And in my contract, it's leaving out the exceptional term, which is a real concern. But that's good. How are we doing those negotiations? Continue.
Regarding the rates, we continue to provide feedback to the department that there is parts of their rate setting process that does not make sense to us, especially as it relates to TCW, as it relates to entity-specific factors that are very important. I will say for Macomb, as you'll see in the 2025 budget, we do think there's going to be enough revenue in 2025 for us, even with the ambiguity of the rates that currently exist. We do think there's going to be enough revenue for us. But of course, we want to stand with our other strategies where it does not look like there's going to be enough revenue for that in 2025.
That's the other comment I wanted to make, Mr. Chairman. I think we should commend both Tracy and work collaboratively with the other non-PIHPs that strengthen, in particular, Detroit Wayne and Oakland, because three of us together are the only standalone, number one. And number two, if you take the three of us together, I think we represent about 50% of the people in the state, pretty close.
Yes, Linda.
I think I sent this today. I have a concern about the implications of not signing the contract because it's the business that we do and it's how we get paid. So can you give me your best guess on the implications of what Nick talked about before when we were asked to sign a contract without a rate, and I think we signed.
We did.
So
Which can I clarify too, we're not suggesting not to sign. So Richard definitely has a question, but we're suggesting to submit. If this goes through and there's not any other changes and there's still concerns, for us to sign it with the strike throughs and amendments, which is just slightly different because we're basically trying to take it active for us to negotiate. I realize that might not change the actions, but I just wanted to clarify what we're requesting.
And the motion tonight is just to take it the full board, because the way it is now, this is not acceptable. I mean, I'm happy that the state is working with us. Congratulations for working, but we're not going to sign a blank check. We're just not going to do it. And so the state needs to know that we're staying united, we're not going to fall, and I think please continue to negotiate with them. But at this point, it's just to go forward to the next board. I would not approve this if this was final. We're not going to sign a blank check. I see there's a lot of language about clarifying, and I might have jumped over some others, but please keep negotiating this. But as written, we need more clarification and more certainty.
Yeah, so to answer your question, Linda, we have started conversations with the attorney at these Region 10, Macomb. We're in the process of getting approval tonight for that and at the next board meeting. The next kind of steps would be if the department does not make any changes in the final version that we expect to come sometime this week, I expect, right? And so I expect that will not be the attorney's recommendation is to strike through the language, replace it with this language that we are recommending, sign the document as amended, and then send it back certified mail to the department so that we have record that they received. So that would happen if the board approved it, of course. That would happen before such another Thursday. The attorney feels strongly that the department does not have the option not to pay us for services. That is because these are statutorily and constitutionally required services in the state of Michigan. It's federally required to be provided to individuals who meet Medicaid eligibility, and we are the entity that is required to do that in the county of Macomb. So to not pay us during the negotiation process, even if that still doesn't exist, would potentially violate federal regulations. So, number one, from that recommendation or from that perspective, I'm not concerned that we won't get paid. However, if we get paid for even a month or two, we would have the reserves to ensure that our consumers will still receive services. So, in no way will we allow this to impact our consumers.
Thank you, Richard. You know, you can get a lot more with a kind word and a gun than you can with just a kind word alone. So please continue to negotiate hard.
So I'm going to give an update on the two other concerns. On the chart you see there, the next is the CCBHC. We did receive the edited, strike-through and edited language in the version of your board package. Just to remind you, the biggest concerns, now to address those concerns in the edited version, is the inability for us to do our traditional managed care utilization functions for these new. Just a reminder, despite other regions not having this concern, Macomb they approved as of October 1st, 1, as of January 1st, 2 more CCBHCs. So we will have, the January 1st, assuming that goes through, we'll have 3 CCBHCs in a 4-mile radius. in a mile-and-a-half radius, providing the exact same thing despite our many educational opportunities of how that doesn't make sense for the people that we serve. And Richard, you're welcome to jump in on this or add, but it's not about the CC, it is about the first and foremost the people we serve and harming our system of care, which then forth harms the people we serve. The second one is the already underfunded CCBHC non-Medicaid. So Richard, that's where I was going to pass the baton as far as where we're at this year, and then a lot of the unknowns that Nick was alluding to regarding the CCBHC non-Medicaid.
So we're already seeing the CCH non-Medicaid for next year budgeted. You'll see that later, that almost $4.5 million, and that's just for us. And so at the moment, the state has appropriated only $5 million to spread across all of the CCHCs in the state. And it's not even if they gave it all to us, it would barely cover our one county, right? When there was only 13 CCDHCs, they split it 13 ways. So we got a bigger chunk, and they added another 15 CCDHCs. Now they're splitting the same pot of money 30 different ways. We got a significantly smaller chunk. So that will continue to happen if we don't figure out the funding mechanism for the non-Medicaid. So that is a significant concern. On the non-Medicaid side, and of course, we have the managed care concern for our communities.
Yeah, just a reminder of managed care when we say those words. That means it is our job to make sure the individuals we serve are getting the right services, right, at the right level, the intensity that they need. That's what we would do. They, in this new contract, if you paid attention to the strike-through items, that ability for the CCBHCs would be removed from us. So what would happen is they would come to that facility, they would do an assessment, they would enroll them, and it literally says must pay them. And you would only have the ability to do a retroactive review. So all the cases after the money has been expended, after the person's been receiving services, we would then, let's say if we found that there was a concern, we would then start the back and forth with that particular provider, which we don't think is a good design for all parties involved. So again, it's our responsibility to manage the funds. So when Richard talks about risk, that's what we're doing, is trying to say we have so much in this pot, and how can we maximize it for our community? But then you also we need to make sure the right person is getting the right thing at the right level of it. So we don't want that functionality to be removed from us. The state, you'll see some comments in there. They did receive the feedback as a positive. They then did some additional edits, but we're just not so satisfied with the level of edits of it. Again, it's the managed care and a lot of the unknowns that we just talked about with non-Medicaid. They've also said they're looking at that. They understand that there's a gap there for the non-Medicaid CCBHC, but they don't have a lot of concrete information, so they're still using terminology, sign a blank check, which makes us nervous.
Nick, yeah, just one final note, because we haven't talked too much tonight, we haven't asked reserve fund. That reserve, that's the whole, and that goes to the rate. That's all connected, because if the rate is too low, we end up spending more for services, and we have to do that. And then when we go into the reserve fund, and the shared risk system that the state has established, we're liable for the first 6%, some percentage that occurs, and that comes out of this reserve fund. And then the state is liable for the balance of that, although they never actually assume that, they locked in and cut services instead, which is a violation of what the law says. The problem is that if we deplete the reserve fund, as they want us to, by sending the money back to them, and that just goes into the state's coffers, it doesn't necessarily go to mental health services anymore. We no longer have the ability to protect them any more than we do to protect best interest of both parties that we maintain a sufficient reserve, considering the fact that the budget is up and down, and always is, the economy is up and down, and considering the fact that most of this reserve dollars are there because of the COVID money that's no longer available, but the COVID needs were long tail. We're seeing the COVID pandemic results in terms of costs going forward, rather than having seen them all during the pandemic itself. So there are a lot of good reasons for this argument on the reserve fund, and I think it's important that we move the process along, but we continue to work closely with the other PIHPs and with the department to come to some sort of resolution, and this keeps those issues alive. If we finalize 2 weeks from now without an agreement, a contract with those strike-throughs, essentially what it is they put a proposed contract before us. We're sending the county. We're not saying we want contract with you, we're just not agreeing with the terms of the contract that you proposed. We'll have sent them a counter. It's my hope, from my discussions with Tracy, I'm not real optimistic, but it is my hope that within the next couple of weeks we will be able to get some movement, and we will be able to approve a contract that both sides can agree to. But you don't have a meeting of the minds at this point, and that's what's necessary for the contract.
There's never a little that is our third. I just want to make sure you see that on the chart, the third is ISF. The good news is again, they are hearing, you'll see their statement, which is the last comment, right? Where they're saying that they understand, they're open to discussing it after, but our stance is similar to the law school in the way that we don't want to, we want, let's figure it out now so we can avoid any confusion in the future. Because I feel again too much unknowns, which you're welcome to jump in and want to add some of ISF.
Yeah, I mean, Tracy's point, the state has proposed, we'll sign the contract as it is and then we'll negotiate it later. And the attorney has been very clear, no, once you sign it, then you have no leverage. You have no. And I don't want to be in a position where we might have to give back some of the ISF and then have to replenish it later when I think the good years are behind us, at least for a few years. The good years are behind us. The bad years are potentially in front of us, and cannot put money that we don't have in. So I will say for this area specifically, we do have the others that are standing behind us with the CCDHC piece. We have a lot of people that are standing with us on the ISF piece. And so this is the language, or proposed language, that Region 10 board also has approved moving forward, and I know a couple of others that are planning on doing the same. So we're excited to work together as a group to hopefully get to an amicable resolution.
Any other comments? Yes, no.
Thank you, Mr. Chair. Jumping back to the CCDHC real quick, the funding for that, is that solely from the state? Is that fed to state to us? I need help with the train.
With the train, yes. So I wish I had a whiteboard. So the money goes from the fed to the state. The state has to put some state dollars to it, so they can match it, right? And then it comes to us in two different payments. We have our base capitation payments that are the rates that Nick has referred to, and there is the supplemental payment. Now, a portion of every day that we provide service, whether it's us or another association, a portion of every day comes from that base cap. If we move some money over, which is financial, and then a portion comes from that CCH. It's that portion that we move over from the base cap that if we run out of that money, we have to put it into the ISI.
Okay, so with the state match, can the state go above the match, or does it have to be an even? Because I'm thinking in terms of, there could be a fall supplemental from the state with the budget. If
more money is thrown in there, could it trickle down? That's kind of the timing of this. Is that a possibility?
We absolutely should be advocating for additional, what we call non-Medicaid CCBHC money from the state. In the non-Medicaid CCBHC, it is only state money that comes in. There is no federal. And you would have to put that on two separate line items. So right now, the non-Medicaid is $5 million. We're hoping to bump that up to, we think that it's close to like 75 million. So hopefully that we get it back.
Did you say 5 and then it's 75?
Maybe close to 100.
So they're off by 20.
They're off by at least
times 20.
At least 20.
But the positive is they're acknowledging, we just don't have it. They're saying we're going to work on it, but it's again that non-middle, we need much more information.
And they come to us and say, sign the contract, then we'll be friends. Okay, yeah. I don't like that approach, and I hope you both lean into this. I know you will, and thank you for working with them. I hope they continue to work with us. I mean, that 7.5%, I mean, you know who's skinny dipping naked when the tide goes up, right? And it's never been enough money. We like to hold on to a lot of cash because when it floods hard. And we do not want to cut services. We don't want to hurt our providers. We don't want to hurt the individuals we serve. And we're not going to do it. We're not going to sign a bad contract. I can't speak on everybody else, but I'm not going to sign it. And even if the heavens fall, we'll let justice be done. And so we'll let them go straight to hell and we'll drag them down. How about that? Done.
Well, between the three of these, you know, between the WASC, the CCBHC, and the ISF, I mean, it looks like it would almost destroy us.
That's right.
That's what I'm seeing, is that fiscally, if we signed this contract with these three pieces in it, I mean, it looks like fiscally, this would be a destruction of Macomb County community mental health. I mean, am I reading that incorrectly? I mean, I can't see how, with the position that we're in right now, that we would survive. Am I incorrect with that?
No, I don't believe you're incorrect. I believe that the state's position is trust us, we won't let that happen. Unfortunately, history does not support that is accurate. So I do consider these items to be existential issues for not only this organization, but for all of the CMHs throughout the city.
So we don't really have a choice but to not sign this and to fight it.
Well,
with every inch.
With every inch. And with our dying breath, we're going to fight it. And I mean, I can't speak for everybody else, but we'll see what happens next board. This motion is just to carry it to the next board. And so, God willing, you know, reasonable minds will prevail, and you know, we can come out to a settlement that we can all agree with, and you know, but if not, you know, so be it. That's their choice, not ours. Any other statements or questions? All right. Thank you, Richard.
I think we have to vote.
Oh, we need a vote. Motion to carry this to the full board. That's all this is a motion for. Is there a motion to carry it to the full board?
The motion's
The
already.
motion is all in support of carrying it to the full board, not approval. Carrying it to the full board.
Well, all the motions.
Of course. Just to emphasize. All in favor to carry it to the full
I
board?
just have to say one thing. I want to make it clear that the stance that Tracy suggested is that we sign it with the strike through, which is different than be damned if we won't sign it.
Well, we'll see how that goes. at the full
I'm
board.
just putting that out there.
Right. We'll see at the full board. Yes, Nick?
Just to make it clear, I think that point is important. Other PIHPs and CMHs, I'm not sure which, well, they're combined consulting have amended contracts before successful by motion of the board. I don't know that they've done this contract, but other contracts with the state. So it's not completely unheard of, and we're doing this in solidarity with the bulk the brilliant metaphors that he's been able to develop to share with you. But the reality is, the hope is that this gets their attention and that we can work out a satisfactory agreement that everybody's in with. That's the end game, not to end up with no end.
Thank you. Yeah, that's right. But this is just to carry the full board. Hope you both can do the best you can, and we'll see you in 2 weeks. All right, all in favor, say aye. Aye. All opposed? Motion carries. Item 5N, request to approve CMH CPO in collaboration with the County Corporation Council to engage outside legal counsel for possible contract actions.
Support.
Motion by Donna, support by Lori.
This is to do what we were alluding to, is to engage only as needed and futuristically. Again, if tomorrow we get a new version of the contract and it's okay, then we wouldn't necessarily be engaging this legal counsel. If it's not, we would be seeking legal support in collaboration with the other regions who have also retained this particular counsel. And again, it's in collaboration with Corporation Counsel. They are on the same page and part of this, and they have been involved in all the communications. And they are actually currently the direct contact with this individual if you approve it.
Next.
Tracy, in connection with the not so language, there was no dollar amount included here. I would hope by the full board meeting we would have a
Yes, and Richard, I don't know if you wanted to kind of explain what the
estimated.
estimated.
Yeah, an estimate or a cap.
Maybe we can explain the current status.
So from a current status perspective, Region 10 is actually retained first. It was the first region to retain. Region 10 is Genesee County, Lapeer County, St. Clair County, and Salem County. Since then, Macomb County Corporate Counsel has reached out and retained, and the Region 1 VP has reached out and retained, and we expect others will reach out as well when their board starts to approve that. At this point in time, Region 10 is carrying the cost of the council. So Region 10 is carrying that for the entire group. If or until we get into litigation. Once we get into litigation, obviously costs tend to go up, and we would, at that point in time, have a cost sharing arrangement that we would want to consider. Obviously, at that point, we would be able to come back with a, hey, here's how the situation has developed, right? And if there is an estimated cost, what that would look like in a cost sharing arrangement.
So you're saying we're going to retain counsel without paying any people?
Council has agreed that they're okay continuing to bill Region 10 directly until such time as we come up with a separate cost sharing.
And Region 10 is agreed?
Yes.
It's something they have a very vested interest, just like we do, in order for this to be successfully resolved.
One of the reasons that Region 10 is willing to offer this to the other PIPs, even though Macomb is in a relatively good financial position with the amount of money we've been able to put into the ISF, and Region 10 is in a similar position, there are other PIPs that have not been able to do that. So we don't want that cost to be a barrier to those PIPs. And yet, we expect the cost to be relatively small in the next few weeks until we have a hopefully resolution of the contract, rather than complicate the relationship.
Donna. Sorry,
I think I know the answer, but I just want to clarify. So when you say these other regions have retained everyone who's in the same council, correct?
The ones that I mentioned, yes.
Okay.
Same council.
Thank you, Mr. Chair.
Thanks. Any other comments? You know, and from my perspective, and this is just my own narrow perspective, I'm fine signing a blank check as it comes to this, if it comes to that, but hopefully, again, it doesn't come to that. But this is just to take it full board. There's a motion. All in favor, say aye. Aye. Motion carries. Item 5O, request to approve CMH SP.
So moved.
Support.
Motion by Linda, support by Dana, and Tracy.
This is approval for our Community Mental Health Services Program, or CMHSP contract. It is a part of the services of direct delivery services. As you can see in the variation, it is a much shorter agreement in comparison to the other ones that you have read. We do not have any concerns with the items that are proposed in this particular contract, and we're recommending that it is approved and working forward to approval. And I'm happy to answer any questions. I looked through it and I don't see anything of any monumental change or concern.
Thank you, Tracy. Any questions? All right, all support? Aye?
Aye.
Aye. All right, motion carries. That was an easy one. Item 5P, request to approve payment to the state of Michigan in the amount of $62,286, $62,286,000 in planning, cash settlement. Is there a motion?
What you have, what you have in front of you is the cash settlement amount for fiscal years 20 and 21, so 2021. So as you can see, this is about 4 years old, 3 to 4 years old at this point in time, and unfortunately that's about how long it takes for us to settle with the department. So it does drag on quite a bit. 21 was right in the middle of the pandemic. It was a lot of revenue at that point in time. And just as a reminder, we have put as much money into the ISF as we possibly can at this point. So there's not any, I would say, room in the regulation with this to retain this money. So before we send any money back to the state, we need approval of this board to ensure that it's approved. So it is a large amount of money. It's a large amount of money that's due from the state's request. It's due by the end of this month. They want payment by the end of this month. Timing, I would be a lot more comfortable if we had a signed contract that we agreed to with the department, but needed to bring this forward to the board to do technically owe this money back to the department.
Any questions?
Were you notified of this years ago, and the money's been sitting there, we made some money on it, or it's just pulling it out?
Yes, so we calculated, when we did the reporting for that fiscal year, put it into the department in February of 2022, when we would have reported it to them. We knew that it was going to be approximately this month. They do take a look at some of like our accruals, and they might tweak it by a few $1,000s here and there, but this amount in general we've been aware of for over 2 years. And yes, it's been sitting with the county, and the county's been investing it, and we've been able to make some local interest off of that. So that's a good deal for us for us.
Got it.
So, you stated that we're supposed to pay this money back at the end of this month?
What the department has requested is they would like to finalize what they call finalize the settlement process. They'd like to do that before September 30th. That's their decision. So they've asked us. We agreed with the money, the dollar amount. We've been back and forth with the department. We looked at their accounting, and we matched it up to our accounting records, and we agreed with the dollar amount. So it's a large enough dollar amount that they can't just pull it out of one of our payments. We don't get paid this much money in 1 month. So we would have to actually send them a payment of this amount.
What if we don't send it?
They don't have to, and I wouldn't ask for it.
They'll send us a really poorly, a mean letter. That's what they'll probably do. Yeah.
So why don't we just not send it?
It would technically violate our 2021 contract if we don't send it at all.
No, I mean, not this month. Don't send it by the end of this month.
I don't know from a practical standpoint. I don't know what would be the big deal from the state's perspective since they decided to wait 2.5 years to wait another month. I don't know what. I don't know.
Richard, this is money from 4 years ago.
Yes.
And they come to us and they say, "Oh, you owe us $62 million."
That's right.
And what, pay us within 30 days? I mean, where's that coming from? It's not like a tweak. You said tweak. I don't know. I wish $62 million was a tweak. To me, it sounds like a lot of money.
Sorry, I should have clarified. We knew about the $62 million 4 years ago. That exact number has changed slightly since we knew about it.
So if it's changed, it probably still can change. I mean, why isn't it 57 million, or why isn't it 55 million?
I mean, at this point,
It's 4 years ago. You know, when debt gets older, usually you can settle for a lot less. I'm sorry. Yeah, Nick.
Yeah. Again, we're just sending this to the full board at this point. If we have questions, you can down to the full board about dollar amount, this can be raised. But at this point, this is the dollar amount you're saying your figures come to and that the state has come to.
yes. So when we have reviewed under the terms of the 2021 contract, how much we believe we should be sending back, we did come ultimately to this number. Yes.
But if board members have some problems with those figures, there's no reason why we can't discuss that on the full board.
I would be more than happy to try to answer any questions the board has about it.
Thank you.
Bill.
Thank you, Mr. Chair. Why wouldn't we discuss it now? Why wouldn't we ask those questions now? That's what committees for. I'm not trying to make my meeting shorter by any means. That's why these committees are here, so we can discuss and debate these thoroughly before they end up in the full board. And I want to know why we can't just send 30 million now and 30 million in 2 months. Sorry, Dick, go ahead.
I was just going to say,
you don't have to answer.
I haven't figured out any questions yet. That's why we can't do that.
Fair enough.
But in the next couple of weeks, I might be able to come up with
Fair enough. Thank you, Mr. Chair.
What other questions do you have? Dan?
I don't really have a question, I just have a comment. I think I understand why we have to send this money back, although I think it's all kind of confusing. But when we talk about these things, what I always think about is that people who receive our services watch these meetings, and they see us talk about sending $62 million back to the state, and so many of those people are struggling to get services, make ends meet, make their lives a little bit easier, and I just find it kind of mind-boggling that this is what we have to do. So, and I'm sure the people that watch don't fully understand, because I don't fully understand. So I just think these are difficult decisions, and I think it's difficult for the people who watch these meetings and receive our services, and I wish there was an easier way to explain things to people and help them understand. And I think the bottom line is I just wish the system worked better, but I don't know.
Linda.
You need to just give us the definition of cash settlements.
So the way that the cash settlement works is at the end of the year, so in this case, the end of this year would be September 30th, 2021, right? The state gives us about 5 months to look back at that year and say, from all the services you provided, from all the good things that you did as PIG in Macomb County, how much revenue did you get? How much revenue did you spend on services? What's left, right? And with what's left, we're allowed to do a few things. We can put some money in the ISF, like we've talked about in the past. We can put some money in what's called Medicaid savings, which we maximize every single year. And if we have paid for the services, and we put money in the ISF, and we have money in savings, and there's still a balance, the contract says we have to send that back. And so this would be the dollar amount that is, after all the services were paid for, after the ISF, after the savings, this is what has to go back to the city. And because of how we carry this on our books as a liability, so it's been on our books as a liability since 2022, it does not impact our budget this year, and it does not impact our budget next year. So it will not change the services available to consumers, even though the cash is.
Nick?
I think part of the problem here, again, relates to the department's refusal to recognize their responsibilities. Here, if we get paid on a capitated basis, and if we spend more than that capitated basis, we first take it out of the reserves, and they're supposed to cover the rest. They don't do that. They never have. The only time I know the state take action like that when that situation occurred, that we went beyond the risk, with PIHP went beyond the risk pool, is they went in, took over the PIHP and cut service. That's problematic. However, so I mean, it does make sense for us to send back the extra if we didn't need that, but that doesn't negate the requirement that they send us the extra if the amount of service delivery required exceeds the capitated payments, because their actuarial firms did a bad job on determining the right rate. So it goes both ways, and I think that's part of the frustration. Ultimately, we will have to cost settle here, I think, but you know, I don't know that there's any reason we should try to do some negotiating. Brian suggested, I don't know that that would be successful, but I do think they need to recognize that risk sharing means risk sharing, not you take the risk.
And Nick, I think it's worse than all that. That yeah, we want to have this ISF fund, right? But at the same time, they're trying to cut that from under us. And so here you're going to want $62 million back. But by the way, that amount in the ISF, you know, that's too much. You can't have a rainy day fund. And then who ultimately, if we ever do hit that time, where things are, you know, we're in the lean years, are they going to come in and provide services? Or are they going to say, oh no, you pony up county? And we know that answer. And so I'm not voting yes on this. I don't know what everyone else is. I mean, I know it's just to go to full board, but I don't like even this part here. And Richard, maybe you can explain this. MDHHS reserves the right post-audit and verification of the amounts reported. I mean, a benefit of a settlement is a meeting of the minds and its finality. You're done. There's certainty. So what? We're going to write you a check for $62 million, and they're going to come back and knock on our door and say, oh, by the way, we need another $5? I mean, if we are going to settle anything, I would sure hope it's going to be certain. I mean, would it be certain?
So I can try to speak to this, but I'm not aware. My understanding of the reason, because they do put that in every settlement letter that they've sent us for the last 15 years. I believe they might be required to do that because the Medicaid rules, the Medicaid law requires them to be able to audit up to 7 years in the past. So I think they include this to make it clear that under Medicaid law, they still have a 7-year look back requirement. But that's my layman's understanding of that. From a practical standpoint, I have never seen them come back and change the settlement after this happened.
Yeah. Have you ever seen anything like $62 million come from this county? Not until today. All right, we have a motion to send this to full board.
One more question.
One more question.
Sorry, Mr. Chair. So going back a fiscal year or two before this, what were the dollar amounts then? And do we have any idea of a year or two out from this fiscal year what it could be?
In terms of settlement?
In terms of dollar amount, yeah.
Yeah. So
if you don't know off the top of your head, that's okay.
The May, whatever they gave you on May.
So going back prior to this would have been first year of the pandemic and then pre-pandemic. I do not believe there was very much going back to the state at all. And the reason I say that is because in that first year of the pandemic, we had basically no eyes. So we were able to put a lot of money into it. So I believe it was going forward from this, if we look at 2022, we did put money into the ISM as much as we were allowed to. I believe there's another 30 million-ish left that we're expecting for fiscal year 22.
We've got 40.
40 million. So there is another
about the timing, the COVID funds, all that stuff. So this is probably as high as it's going to get, especially if we start chewing into the ISF, putting more in that. We should be seeing a lower amount go back.
This year is really a perfect storm because we had three factors that were huge in 2020. Number one, we had a lot of revenue coming through from the pandemic. Number two, it was a year where a lot of places were still closed down for the whole fiscal year. So getting services during that fiscal year was very difficult for consumers. Not because we weren't authorizing the services, but lockdowns and other things that were occurring then. And then third, we were still in pain. This would have been the first year that we recognized, hey, last year we had a lot of money, more than we planned. So we were still trying to figure out how to bring those services. So all of those things happened in one fiscal year. And then we started utilizing the money better. 2 or 23, 24%. Yes, it's going to be a decline in terms of 79.
Thank you. Thank you, Mr. Chair.
Any other comments or statements?
Just want to support Richard's gave the financial outlook, but if you do look at the number of services provided and then the kind of the wave that has occurred, that is what is occurring, and it's also Nick alluded to it earlier, we have provided more services year over year since then because the needs of the community we serve kind of continues to increase. So that is also going to ultimately reduce the amount of available funding we might have to return. But it has been a slow build-up for all the reasons you just mentioned.
Yes, Nick.
To those of you who have been involved in discussions on rate making, et cetera, the other part of the perfect storm is the number of Medicaid. The required recertification of Medicaid, so the number of people, the base that are capitated rated based on has gone down. But has the department acknowledged the fact that the ramifications of the pandemic are hitting now more than they were hitting during the pandemic, and that the pandemic money ought to be adjusted to try to deal with that problem? Is that part of the discussion?
I would say from the PIT to the department, we are telling them that that is a true situation. We are telling them that we expect the acuity or the needs of the individuals who serve in our community going up year over year from really 22, 23, 24, 25. We expect an upward trend of the number of people we need to serve and how much service is given. I will be honest. It's been true for the last 5 or 6 months on all of these issues. Contract issues, I don't know that they're hearing. We're telling them, but I'm not sure that they're hearing. So when we had the rate setting meeting last Friday, I did not hear them say, nor could I find in their materials anywhere that suggests that we built in a factor the rates that assumes that service demand is going to be higher because of post-pandemic. So I'm not hearing them say the thing that makes me comfortable that they understand what we've been telling them.
But it's on the table.
We put it on the table.
We put it on the table.
I don't know if we could have said it any better than we have been. We've been telling them.
I'm telling them so it is on the table, and I know just from my other work that a number of the advocacy groups are raising the issue of the rate process and the problems that we're experiencing. The overall number of Medicaid participants has declined as a result of the recertification process, but the percentage of those Medicaid recipients who are receiving mental health services goes up because those haven't what? We did a good job. We do good job sometimes, but we did a good job of making sure that the people in the system got recertified, which is what could be done. Some of the others have fallen off. That impacts our managed care rate, and that ought to be taken into consideration. So you have the perfect storm includes both problems. One, that people didn't, that the number of certified Medicaid recipients has gone down, the rate making is supposed to be actuarially sound, so it should at minimum take into consideration the percentage of Medicaid recipients who are in need of and seeking mental health services. And if that goes up, that ought to be taken into consideration in the rate making system, as it ought to be, as should be the fact that the post-pandemic surge in the need for services has increased because of the pandemic, and that the pandemic money should be allowed to somehow move forward, which is our argument on the reserve fund. So, I mean, I think you're making the right arguments. You just got to keep the pressure.
Any other comments? Well, there is a motion. Nick, you know parliamentary procedure. Is there any rule about calling a roll call vote on this? Could we do it? Okay. I mean, I just think, I want my vote. I'm going to vote no. There's 8 of us here. We passed the full board, then we need 5. There might be
7.
We need 7 to pass the full board?
Yep. Majority serving.
Well, that would be 7. Okay, that would be fine. So if I vote no, it still goes to full board, but barely.
Well, only if everybody else votes yes.
Okay. Yeah. All right. Well,
you take the vote, and
count the
the
noes.
way we've traditionally done it is we've taken a voice vote, and anybody who's voting no gets recorded as a no vote.
Yeah. Okay. And there's nothing. You could always amend an agenda the day of the full board meeting, obviously, if something else comes up. So you could always amend an agenda at any time. But all right. All in favor, say aye.
Aye.
All opposed?
No.
It does not get going forward. So
I thought you could.
this is to go to full board. We move it to full board.
I thought the motion is for it to go to full board.
Yes, it is.
Oh, yes.
So
Okay.
your
sorry.
aye.
But you said you were going to do the other vote.
I'm sorry.
Okay, sorry.
All right, let's try it again. All in favor, say aye.
Aye.
All opposed? Me and Don. Does not move the full board.
No.
7.
It's only 7
Who said those are 5?
I want it to go to full.
You wanted to go to full board.
Yeah, but Donna and Ryan.
Oh, there's still 2 no's. Okay, sorry.
Richard, I'm going to call this vote one more time. But I want to tell you something right now. I'm going to vote to go into full board. If it is right here, I'm going to vote no in 2 weeks. You hear me? Yes?
I hear you.
Okay. All right.
Richard wants it to go to full board?
I don't know. All in favor, say aye. Aye. All opposed? Don. You got it by 1 vote on the 3rd try, Richard. This meeting has been the worst meeting in my last 6 years. I hope there's good news coming up.
Yes, here it comes.
All right.
Some perspective. I think this is a great discussion. I appreciate it.
All right. Thank you, Richard. All right. It is enough. Item 5Q. Request to approve $1.15 per unit stabilization for all CLS overnight health and safety providers. This is not apply to self-directed providers. Is there a motion?
So moved.
Motion by Dana, support Lori. Ken?
Hello.
Hi.
Hopefully this is the good news.
It's all right.
So, as we've been reporting throughout the year, what we've seen, I believe is what we're seeing last month, but we're showing a surplus in our monthly financials. And in conversations we've had with our provider network and trying to collaborate with them, we've heard that the CLS rates, which is tied closely to the overnight health and safety, they're going to say that they are different, but same type of provider, same locations, that kind of thing. So we tie those together that they can successfully recruit or retrain go back to 10-1 and add $1.15 per unit to all those services. So that would be $4.16 an hour for those providers. So we, this is a fairly significant dollar amount. I calculated it at $7.5 million, which we can afford. And also, part of our sustainability and the budget here in a little bit, but bringing those rates forward into the next fiscal year as well. So I think this will be good for the we did. I'll address that last sentence there where we did scope out self-directed providers from that study. I had a few reasons written down here. One of them is in a self-directed arrangement, the person served is actually an employer. They don't have facilities and overhead and all these different things that they're trying to operate out in the community. Additionally, as we're realizing we're late in the fiscal year, but want to ultimately improve it in this fiscal year, those arrangements require a specific contract for each person. There's a budget that has to be done. All the claims would have to be rebuilt after all of the contracts were rewritten and the budget's done. It creates an administrative burden on frankly both sides. So, and additionally, it's possible that some staff may have moved on if you're in one of these arrangements and you're trying to track them down and pay them and that kind of stuff. So I think it's difficult from that perspective. So that's why we have that written this way.
Any questions? All right. Thank you, Ken. That is good news. All in favor, say aye. Aye. Motion carries. Item 5R, request to approve MCCMH 2025 budget. Ken, motion by Donna, support by Phil.
Okay. We're going to chop this up a little bit. Taking this presentation a little bit. I'm going to start on page 2, just at the top there, and talk about revenue a little bit. As Richard mentioned, we had a rate setting meeting last week with the state of Michigan. They feel that I would call it fairly general information about rates is pretty good to go with, but we don't have the final detailed rate schedules and the rate certification in our final. Ultimately, what we did, I'm going to call it the lowest increase in the information they presented by population was 4%. So we budgeted all of our revenues at a 3% increase to try to be conservative as we can on that effort. Ultimately, if we get those final rate schedules, ideally we'd have the information to bring back to the full board that would be different and likely better news if things pan out the way we anticipate at this point. As far as our other revenues go, I can get into some detail later in the schedules, but general fund revenue continues to be flat. I approved the CMH contract earlier today. That amount has been the same. This year, the same. Amount, and ultimately don't foresee any changes on the horizon that I'm aware of. So there'll be two kind of big ones.
Continuing on page 2, I'm not going to read every point that's on the front. I'll make some highlights that are some of the expense assumptions that we built into the budget. And I'm going to start from the lowest cost and work our way to the provider costs. So the way we approach this is working with each of our cost center managers and all of our departments, ensuring that their individual budgets accounted for their needs at the department level. So that was one layer, just ensuring that their budgets are appropriate. Working our way then to labor. They're assumed based on our needs, based on our main table and the FTEs that we need to support our network. We fully loaded the budget with all of the positions, including the vacant positions, anticipating that we're going to have good luck in filling those roles to support our people. So that is included in the budget and represents probably 50 vacant positions or more. But those are in the budget fully loaded, as well as in January, we increase that is coming to the county. That is also in there from our labor. So that is a good portion of what would have been included in the labor. Then we move to our provider costs, which is, of course, our largest cost, and there's about a $20 million increase there. We've done a lot of work, as Ken just mentioned, with our CLS providers. We've had multiple conversations. We know the challenges there, and we've increased the rates in the CLS services. There's a substantial increase in our provider costs, probably to $7 or $8 million, if I remember correctly. $7.5 million. The other big component here is we've done a lot of work this year with all of our specialized residential. We have met with more than 50 of our providers. We listened to the needs, to the challenges, and we have done a lot of work to move towards a standardized rate and increasing those rates where we can. A large portion of our provider costs is an increase in our specialized residential to meet the needs and the challenges that they're having with labor costs. So that's built into the budget. We gave us another substantial increase, just shy of $5 million. So we also then looked at all of our other codes, and other than H 2014, which is skill building, which we earlier in this year we addressed and we increased those rates. Everything else we've increased 3% to account for some inflation factors. So really looking at this budget, looking at our provider needs, invested quite a bit in increasing rates and availability of funding for our providers.
I'll add one more thing, Tony, that the state did include a 20-cent ECW increase per hour. There's a 12% admin load on that to try to get something to visible blackboards. 24 cents an hour, 6 cents a unit. It's something that we'll have in the budget as well for that. It is small, but something that has happened as part of the budget.
Yeah, there's a point on that on page 3. So a number of the comments that we're making are included in the narrative. We went for every single dot point. A couple other things just on the general fund. David mentioned, but we're expecting the same amount from the state, $7.4 million. But you're using that for the spend down services and those needs that are now part of our cost structure. So those funds will be used there. And then from the county perspective, we usually get about $3.7 million. Again, we're not requesting any increase there, just continuing that $3.7 million funding from the county. Just a couple other points. On page 3 at the top, we just noted that for the PA2 budget, about $3.4 million, just a slight decrease. And that was related to a change in the allocation methodology, but that wasn't substantial. Under general expense assumptions, we talked about the fully loading of the positions. We have the 3% increase noted. Ken mentioned that the provider network is 24 cents. Last piece, just from an overall cost perspective, we built in a 4% year-over-year inflation factor in the expense structure. Any questions or yes?
Okay, if I'm reading this correctly, my first concern is that there are a lot of numbers in parentheses, basically red ink. And that concerns me. We only received this today. So I read it, but I don't pretend I'm going to guess it. It's much more complicated, and I realize they can be amended and changed if they're only estimate. But why is there so much red ink? Number one. Number two, the amount that the county is supposed to put into the pot is a percentage of state dollars that are provided to us. We're still an agency, we're not an authority that freezes it. Why are we freezing it instead of doing the actual calculation on what the county's contribution is supposed to be to the law?
I need your help on that before you can.
So, Nick, I think we can talk about ready. You mean on the pages 4 and 5?
Yeah.
Okay. So if you don't mind, I'll tackle that one in a few minutes on those pages. far as the local percentage, as we look at our local funds, we've mentioned that we've been able to generate a good deal of interest off of some of the state dollars that Richard went through that we held on to. We've also generated a seed surplus that's local, and our local obligations do not exceed what the county provides. So in an effort to not burden the county's budget, we've kept that revenue flat.
But the state law says the county shall pay us 5%. I don't know the general, it's not Medicaid money, it's state dollars that come to us. So there's a calculation that should be made as to what the statute provides. You looked at that?
Richard, I'm going to need your help on that one.
And I would note, for our purpose, I'm not going to object to sending this before the board, but I reserve before Phil goes holistic here again. I mean, the questions that come up, I'll try to clear some of them up before the full board meeting, but it may come up at the full board meeting because, like I said, we just received this today, and that's not enough time to digest the budget. In my estimate, it's not enough time for me to digest the budget. Good. It hasn't registered yet, so I reserve the right to raise questions between now and the full board meeting and at the full board meeting. Our fiscal year is October 1, so it's important to do something. The county's fiscal year is January 1, so there's some wiggle room in ending. Rather than just simply not about but I wouldn't really share a lot.
So what's tricky is that so under the mental health code, the county contribution calculation was at 10% of the general fund allocation from MDHHS. Unfortunately, what's happened is over time, that section of the law was written for Medicaid managed care to happen. Back when Medicaid was called state Medicaid. I'm sure you know.
I would think.
So since then, there are other local obligations that we have that are not part of that calculation. So the 10% of the general fund, that's one piece. There is the state facility costs where we pay a local portion of state facilities. That is a local contribution that is separate from the general fund calculation. And then we have what's called the local match drawdown payment, which comes from the related to our Medicaid. So every year we play a little, kind of like the MRS match that was approved. We send some money up to the state, they use it to bring down some extra federal dollars that can get Medicaid insurance. So we have done the calculation, right? And we talked to the county, and we indicate what we would like our request for the county appropriations to be in the neighborhood of that. So what we've included in the budget is what the county has agreed to. Basically, do you need more than you did last year? No? Okay. So that's what we did.
But there's a lot of ready.
But not related to our local funds. And I might have to explain that better at full board. In terms of our local fund dollars, we actually have a surplus related to some of our CCBHC and our Medicaid. There's a little bit of red ink that we might have to dip into. So when we became CCBHC, we did sign up for some risk that is not the county's statutory requirement. And so, to the extent that we might dip into a little bit of fund balance, which, again, fully loaded this budget with all positions filled, so I don't expect that to actually occur on day one. So there may be some vacancies, there may be some attrition. But to the extent that we might use a little bit of red ink in 2025, it would come from the surpluses that we generated for CCBHC in 2022, 2023, and then now 2024. put I'll call it a CCBHC reserve. It's separate from our ISF. It's separate from all the other discussions. But we've been able to put a CCBHC reserve together of 20 plus million.
I think it's going to be approaching 30 at the end of this year.
It's almost 30 million related to CCBHC.
But CCDHC is losing. That's what you monthly.
CCBHC has a cash deficit where the state's going to owe us money at the end of the year, but a part of that we can get to do as local service. There's some.
Can I ask over to the CCBHC non-Medicaid, which is what we were talking about earlier, which is deficit. So those are two separate funds, what Richard was saying. And
Yeah, the county doesn't match the federal, or it doesn't match the Medicaid. It matches mental health company. It matches the general dollars, close to 10% of that. And I understand, the calculation, your concept. My understanding, maybe I'm misinterpreting how we actually do things as opposed to I'm used to it. But they're supposed to give us 10%, and then we pay the county for services they provide for the agency, like room, various things, the payroll, et cetera, et cetera. That's fine. It sounds to me like you're saying you do that before you figure out what the county pays us. You do the offset rather than doing it as two separate lines. One that says this is how much the county owes us, this is how much we owe the county. This is the difference, and you're just showing us the difference.
Not exactly. So we include what the county bills us is included in the expenses. What we ask of the county in terms of general fund appropriation, we show it the transfer to the county, show it the county appropriation list. And what I'm saying is that because we can't take the non-Medicaid CCBHC program and calculate 10% of that, there is no match requirement for the county under that piece of it. We believe that what we've included in the budget is the appropriate amount for the county. But I'm happy to go through why I think that in detail, either at a full board meeting or offline.
Again, I'm not going to object to moving this forward to the full board, but I'm uncomfortable with a number of things in this budget, and I'm not even sure what I'm uncomfortable with, which is really a bigger concern. But I do have phone numbers, and I'll try to get some of that resolved before the full board meeting, or Richard will be available to answer those questions after that. So,
Yes, somebody will be prepared to answer that question.
not just that question,
Other questions.
the housing question.
And as always, as stated, absolutely, if the questions were to submit ahead of time or have them then, or we will call through the detailed information.
Anyone else have any other questions? Thank you, Dick. No other questions? Thank you, Richard, Ken, Tony, thank you. All in favor? Oh, wait. More. I'm sorry.
We
We
got more.
Yeah, more.
I do want to highlight page 3, at the bottom, we've included this other significant budget items. I'm going to say that these are things that are some of them are uncertainties, and a lot of them have already been covered in the agenda today. Bullet number 1 relates to the ISF. At this time, we've gone through that point today. We did not budget to have to pay anything back to the state. However that shakes out, we might have to come back with a budget amendment. Bullet number 2, I think we talked about a little bit where the state is.
Where are you at?
Page 3.
Page 3, section 8, bullet 2. So we talked about the 49% rule, I think, where we are only allowed to provide 49% of our CCBHC services through DCL. Essentially, we are higher than that. So we've had to scale that down. Our and the related expenses were only reduced $4.1 million. So there's a disparity and a loss there effectively as a result of this rule that the state had. We did fight how they were calculating this, and we fought the good fight, but ultimately did not prevail in that effort. Bullet number 3, again, another big one we talked about, evaluating the 3 new potential CCHCs sometime in fiscal 25. With the PIP contract uncertain, we ultimately wouldn't have contracts with those entities for them to provide CCHC services on October 1. So at the end of the day, that's something that we can't predict right at this time. So ultimately, we may have to come back to an amendment of that as well. Number 4, conflict-free access to planning. There may be additional FTEs that we need as part of this effort. We don't know what the details of that particular effort is going to be. Again, another uncertain item that we want to bring to your attention that, depending on the impact, we might have to come back to on that as well. Number 5, hospital tiered rates. That's been a discussion topic, but ultimately our understanding at this time is that MDHHS is pushing that additional revenue through the hospital rate adjuster payments and not through rate changes to us. Again, should that change, we might have to amend. Bullet number 6, we talked about the My Health Link program. We're winding that down. We've decreased revenue to match with that wind down, essentially maybe a little less than a quarter of a year's revenue to match with that. And then the last bullet is just that the opioid health home is changing to a substance use health home. It expands services based on diagnosis. I could ultimately expect there to be more people eligible for that service. So we would have more payments for that service, more expense for that service, but that those would be largely budget management attention as well. Going to page 4, I think this is where some of the red ink starts. Like I said, we only hit some of our expense assumptions. I'm going to group some things together for the purposes of a total analysis. So when we look at the Medicaid box at the top, you can see that we're running a $5.3 million surplus. And then if you look at the Healthy Michigan box, the second box, we've got a $5.7 million deficit. So we have this imbalance between how much revenue the state is giving us based on those programs. When we look at, as Richard mentioned, how we put our money into savings, how we put it into ISF, and how we settle with the state, those numbers are added together. So I would offer the way that at least I think about this, adding those two numbers together, it does show a net deficit of roughly $400,000. Just to highlight some of the things that Tony said as well, we have 50 vacant positions, their budget at the top end of the range, if we feel that the talent is going to be difficult in this environment, we'll have to pay for it. So there's considerations there when we look at the budget. So it is, I think, a modest deficit. When we look at what our eligibility trend could be, could easily fluctuate about $200,000 every month. Any questions about the top 2 boxes? Try to take this piecemeal if that's okay.
I did see Nick with a hand up. Nick, is your question answered?
I'm going back to the assumptions pages, not those 2 boxes. I'm just going to wait for that, but
Sure.
Budgets are estimates and they're based on assumptions, and assumptions can make or break. If you adopt assumptions that are not ultimately accurate, then your budget is going to have to. I understand that. I don't have a problem with that. But assumptions are never 100% accurate. They're an assumption. What you just told me, though, is that what you're assuming in building this budget is that we don't know in a number of key areas. Not only do we not know, and reasonable assumption about what that goes to the activity problem, it goes to the rate making problem, it goes to lots of other problems, but it gives me even more pause about the validity of this budget. So you just reinforced me that I think we need to have more discussion on how this budget was built, because it's built on non-assumptions, not even non-assumptions. That's built on the we don't know. That's not a good way to write a budget.
I would say that it's built on the best information we have right now.
But in a number of those key areas, the best information you have right now is no information. And that's problematic. I've had this, I've spent half my life working in public sector budgets, but the reality is that, and I've had this argument with budget directors over the years, that making assumptions that are not valid, I've seen budgets fall apart because they made assumptions that they knew were not accurate. Now we're making assumptions that we suspect are not accurate because of other considerations. That concerns me. Again, I don't argue putting this in the book, but I'm just saying. There's a lot of questions and concerns I still have about this budget. You have not allayed my concerns.
I share your concern. So,
that doesn't allay my concerns.
I think it's a fair statement. I mean, it presenting these bullets, in the interest of full transparency, I think we have a budget that we need to operate under going into next year. It's by no means perfect. Previous years, I'm going to use the word benefited from the public health emergency. Revenue was high. We're kind of settling back into our new normal, not to use the cliche term too heavily, but at this time.
And we all do that.
Yeah. So I hear you. Okay, we have more information, clearly bring it forward. I'm going to go back to page 4 and move on to the boxes 3 and 4, if I can call that. Again, when I look at this, it's kind of the same as boxes 1 and 2. When I look at the CCH navigation for the CCH Michigan program, looking at them in totality is how we settle these. If you look at our surplus and deficit in these two programs, it's roughly $1.56 million going into the next fiscal year. There's a couple of things going on here. As I mentioned, the DCO services, which are ultimately cheaper than our direct services. The reason being that our direct services are depending on folks and it just costs more money. So the cheaper DCO services are going down and the related revenues going with it. Additionally, we have, again, the fully loaded budget with those positions. Roughly 80% of our direct run costs flows through to the CCHC program. So, seeing some of those effects on the funding source budget here, I would offer that those two numbers added together, when you consider our surpluses and things that we run, the CCHC program is certainly a net positive from a finance perspective. But I'll build on one about the other uncertainties. We've talked about the 3 new CCHCs. I don't think it's unreasonable to budget a loss in this area. Any questions about Medicaid CCHC before we flip over to
Where's this?
this one's a deficit. So the 1.5 million, or almost 1.6 in box 3, plus a small surplus of 23,000, comes out to a net of 1.57 or so. Down at the bottom here, we have taken our, I built in what we think the ISF might be at the end of the year. That's also, we're engaging our actuary firm. We have to get an ISF And that savings is budgeted relatively flat. Flipping over to page 5, you can see we talked about our CCHD non-Medicaid program on a monthly basis here today. Funding is not sufficient. This was the $5 million statewide Richard mentioned earlier. Even if we had that, it would barely cover just our one county's cost. They gave us $352,000 roughly. That's the specific GF allocation number there at the top. That was our piece of the pie in fiscal 24. We carried that forward to fiscal 25 as a budgeted estimate here. You can see there that our net deficit there is almost $4.5 million. I will say in this particular piece and with the general funds section below it, we are targeting efforts. We have a meeting tomorrow. This is, to me, a worst case scenario for our non-Medicaid budget. We have a lot of people that have rolled off as the public health emergency ended, the re-enrollment. We're trying to look at those folks that are getting GM and targeting our efforts on to get back on Medicaid. You have private pay now. What is your situation? So those efforts we've got ongoing through the year, but we expect that to be ramped up as we go into the year. So everything in here, I think, is a fairly conservative estimate we have at this time. But I want to highlight that here. You can see our state general fund, we projected that to be a deficit of roughly $250,000 as well. So again, tying that in together, I would expect that number to go down because we continue our work on the GF. And then lastly, you can see at the bottom of page 5 what we expect to put into our local funds at the end of the day. Again, that's partially, we don't spend all of our PA2 allocation every year, so that it's there. And any savings we might have, there's interest in there, so we scaled our interest number back considerably as we talked about the last. We won't have any dollars available, but that's also in there as well. It continues to be a significant number. Any questions about this breakdown?
Yeah, on the CCDAC, non-Medicaid CCDAC. As I understand it, the concept of CCDAC allows us to build other things. If the person has insurance coverage, we can build them. How do you account for any revenue we get from individual self-pay or from insurance?
It would be net against this number. But I will.
That's included in one.
That would be net against our expenses.
So we don't have, we don't know what we're bringing other than the state.
I don't have it on the sheet, but I'm happy to have it. Okay.
Because I think that's one of the components of the CCDAC program that I find most useful for consumers is that they don't have to figure out what their insurance covers. They don't have to figure out whether they're Medicaid. Trying to maneuver the Medicaid system is a nightmare. Everybody says anything to deal with it. So the fact that we take that off of their backs in the CCDAC program is probably the most beneficial thing to provide, and that necessitates our ability to bill insurance companies where the person is insured as well.
Absolutely, and that number is ranked up over time as well. As we contracting with the insurance companies is the insurance process. So we're taking them one at a time. We're handling with a number of them now. So when we look at it,
nightmares, but we're doing it instead of forcing people who are having home problems to create a new anxiety problem by trying to figure it out.
and it's worth reiterating with the CCHD non-Medicaid in particular that if they have a CCHD eligible code diagnosis, we can't turn them away. So that number, the state general fund, we have a little bit more control over. We can
6, just another presentation of the budget or revenue and expense compared to where we are June annualized to the 25, 26, and 27 proposed budgets. I'm just going to propose maybe to this board, given the questions that we had this evening, to maybe break out some of these variances as a follow-up to this meeting, because you may have questions as to why there's a change from the June annualized into the 25 budget. Some of them we can explain, like we talked about earlier. If you look at June, let me just take you to one number. If you look under operating expenses, look at general administrative, part of what we talked about earlier with the positions, the FTEs being totally included in the budget, that's part of that variation. There's other things in there, so it would be helpful if we break that out. The provider cost network is another very large increase, going from 228 to the 247. Some of that is what we talked about earlier, funding CLS, funding special ed residential. So it would be helpful to this board if we break some of that out and provide it as a follow-up to these other questions. Does that sound reasonable?
Thank you, Tony.
Sure. There are a couple other pages in the packet, but those are just different presentations of how we do it. It's the same budget, but presented in the county format, so I don't know if we can go through that today. We just include it in the packet because obviously once this board approves it, we will then work with the county to propose this budget in the format that they requested.
Yeah, pages 9 to 10 are strictly to same numbers turned into a different reporting format. So we don't include the detail of the previous 2 pages in with our county budget because they don't need it as part of that appropriation approval. Just want to make it aware of that.
Thank you, Ken. Thank you, Tony. Any questions? Okay. All in favor say aye. Aye. All opposed? Okay, motion carries. Thank you both. Receive and file. Wraparound and SED waiver presentation. Is there a motion to receive and file?
So moved.
Motion by Lori, support by Dana. Linda. All right.
I do have a question about it. We're just, we vote, right?
It's just a motion to receive and file. We're not voting.
The receive and file is a very good report. It's a very good program, and I think things need a few more words than just receive and file. So thank
Well,
you.
we're going to have some more words right now.
Oh, she's doing the
Lovely Lisa.
I didn't call
I know you guys were, the last one he got canceled, so she's been so gracious to rearrange her life to come back again, so we greatly appreciate it. We apologize that this meeting went a little long.
Do they have the handouts?
Thank you in front of
Oh,
the
okay,
other
awesome.
PowerPoint.
Okay. I don't know if this is working or not.
It's not working. Just talk loud. I said you talk loud.
Yeah. And then I have these two.
Yeah, if you want, you can, Helen can grab it from you and then just pass them on.
Okay. Okay, so here's the good part of the meeting. Thank you guys for having me. This is my first board meeting, actually, even though I've been at CMH since 2012. My name is Lisa Kloot. I'm a clinical supervisor at the Children's Department for CMH, right on Dunham Road, by the jail, in the VERF building. I oversee the wraparound and SED waiver programs for Macomb County. And I've been involved in wraparound since 2008 with the state at different locations in Metro Detroit. And I'm excited to share for a few minutes just about wraparound in general because it's definitely a passion of mine. I wouldn't have been working with it since 2008 and wanted to share what we're doing in the community with children and families. I'll be talking about what WRAP is, what SED waiver is, how can our children and families access that in the community, what is the function of our community team, and the different impacts that we're having in Macomb County for the classroom. So what is wraparound? Typically we're talking about Medicaid and insurances, everything has to have a name, or we call it a program or a service.
But wraparound likes to be known for a process. It is a process that we do with families and children. It's voluntary. We do a lot of the same things that other CMH programs do. We're strengths-based. But the wraparound dives a little bit deeper with families, and we look at the underlying need. We support them through team planning, kind of like what you guys do here, and it's always determined by the family. So one of the things that we usually say to people who are referring to wraparound, you join when you refer. You're not just referring to us, you're referring with us. I will go into what the process looks like and what our kids look like, but just something to remember with wraparound, we're really looking at a 4-sector team. So it's not just the child and the parents, we're really looking at any of their natural connections and natural supports. We're looking at system participants, so the school, the juvenile court, any of the systems that are involved with our children, foster care, CPS, child protective services, and then community representatives. So that could be organizations, clubs, different activities in the community that our children and family are part of, churches, anything like that. This picture is actually one of our wraparound children teams drew and kind of spelled out wraparound and kind of said what it meant to him. So I wanted to include that. That is an art from one of our teams. This next slide talks about the values of wraparound and the wraparound process. A lot of them are very similar to CMH services. You know, we should all be focused on people's well-being. Safety is non-negotiable, right? Individualized, culturally competent. One of the things that wraparound does best is looking at systems and being persistent in breaking down barriers. All of our kids are multi-system involved. We have the top tier kids who are in the most need. So these are kids that are in and out of our ERs, sitting for weeks at a time waiting for an inpatient. There are kids coming home from Hawthorne State Hospital, out of the detention center, through the juvenile court system. Our kids are the kids that have had 10 foster care placements in 12 years of their life. So these are the kids that are really involved in a lot of systems. And wraparound demands that everyone participate in helping us get stay in the community, because it's not one person's responsibility, it's all of ours. So a lot of times wraparound is looking at changing the plan instead of blaming. Some other values is community-based, strengths-based. There's a part of wraparound where we partner with the parent. It's a collaboration. We spend time with the parent, with the family, with the grandma, to really understand the family. Outcome-based, and we are cost-effective and responsible. And so we are, wraparound requires that we monitor outcomes, not just quarterly or yearly like most programs. We review outcomes and measure success monthly, if not more, to really track where we're at and if we're hitting the mark or not. So, who are the kiddos that we see? I started talking about that, but wraparound is a Medicaid state covered service. So it is right now solely for children who have Medicaid. They have to meet 2 or more of the criteria that I have listed. So we're really looking at multi-system involved kids. They're at risk of out-of-home placement. A lot of our kids are adopted kids. These are the kids that families are at the point where they want to terminate adoptions. The children are at risk of being, locked up for long term. So the kids that are at risk of that. Wraparound kids are kids that have been served through maybe other levels of care. So maybe they've tried outpatient therapy with minimal success, or they have a psychiatrist, but but they've only tried 1 or 2 meds and they're still not stable. It's for the kids that traditional community-based options are not always helpful. So a lot of our kids, talk therapy, CBT therapy is not going to be helpful. They've done it, they've experienced it. So they're the kids that are a little bit, we have to figure out how to intervene. And also our kids are ones that have multiple providers. So it's not uncommon for our kids to have different providers when we first get them, and the wraparound team kind of helps coordinate to bring them all together. So if a kid needs wrap, there are ways to get to an intake. Our MCO line, which is the hub for all services through CMH in Macomb County, is on there, and just requesting an intake to be screened for wraparound is really all a parent has to say to get to our department. So these are the 4 stages of wraparound. So a kid and a parent comes to our clinic, they get a full intake. Our intake clinicians are wonderful. They get all the different assessments, and then they get passed along to me to assign to a wraparound coordinator. That person is that family's now primary case holder for CMH services. That's the person they go to, they call, that's the person that submits authorizations and does their planning and assessments. So they get to know the family, and what wraparound does is the 4 stages. The first one is hello. So those are some of the questions that the wrap coordinator should be thinking about when they're meeting a family. We talk a lot in wraparound about hearing the family story. So it's not just about, oh, when did the child start having issues, or around 5. It's, how was your pregnancy? How was your childhood as a mom? What challenges did you have growing up with your parents? What was that like? So we really want to not just go when they got their diagnosis for their kid, but really back to how they were raised, what things were helpful for them, if they have trauma, and things like that. In this phase where the wrap coordinator is working with families, we do crisis and safety planning, and then we talk about team members. Who do they want on their team? So I talked about the 4-sector team. A lot of times families, when we get them, they have a lot of broken bridges. A lot of family members don't want to see them anymore. Grandma doesn't even want to babysit the kid because the kid stole from grandma. And so we really start talking about who are those people that they would want to rebuild those relationships with, and who are the new people they want to bring on. I listed some of the services that our children have. These are all Medicaid covered services. Some of them are also services you can get with private insurance, like occupational therapy. Our kids tend to have at least 3 Medicaid services at any given time in addition to wraparound. Some can have as many as 7. So their professional part of their team can get really big in the beginning to help stabilize the child and keep them in the community. This is just about safety. So just like any service at CMH, we don't negotiate safety. My rec coordinators are safety planning with really, really high-risk behaviors with kids in the community. Human trafficking, sex trafficking, self-harm, overdosing, just really the most high-risk behaviors that we have in the community for our kids. And so really the whole team is part of safety planning and crisis planning. We also talk to families about there's a difference between crisis and safety. So we all have crisis in our life every day, things that can put you into crisis. But really safety is what the wraparound team should be helping them lower. And then learning how to deal with crisis. Because crisis is not going away, even after wraparound. The second stage is the help stage, and this is about creating the beautiful, person-centered plan, wraparound plan that has all of those services listed, but also other creative approaches to help our wraparound youth. We do family vision statements and mission statements, which is something that's also different from your typical person-centered plan at CMH. The mission statement is to really drive the team, to excite them, to get them motivated, to remind them why they're there. And the family mission statement is really what they want to see at the end of wraparound or in their future. So I put an example here. They did like the superhero word with all the different words that came from it, like successful, unique, patient, exceptional, ready for anything, happy, empowered, regulated, and optimistic. So one of our families actually sat down and each person in the family picked something that they really want that they don't have in their family right now, and then they put it all together in that acronym. In the help stage as well, that's when the wrap coordinator is going to really be focusing on planning that first team meeting. In wraparound, every system participates. So we have meetings at the home, in our office, at the schools, we meet in the ER, we go to Harbor Oaks, we go anywhere the kid is, JJC, to lockup, to there, and we have team meetings. The important part of that is really making sure everyone's on the same page. These kids do not need 12 meetings to talk about the same thing, and they don't need 12 people doing different things to help them. They really need everyone on the same page. The third stage is the healing stage, and this is when families really start to see change. So a lot of that high crisis is when the safety is a little bit more regulated, and we're actually able to do some really creative things with our kids. The healing stage is really working the plan. We come together as a team as much as needed, but our wrap coordinators are with families weekly. It's very intensive, and if something's not working, we're throwing it out and we're trying something new. We're not waiting 3 months, 6 months, 9 months to see if a certain technique works. We're really trying to get the family to hold on to that hope that change can happen quickly, because they don't have time to wait. And the kid doesn't really have time to wait either. It's too high risk to wait. Just like you guys have here, we have agendas at our team meetings. They're ran kind of, I mean, not as serious, but like they're ran kind of like this, and there's someone taking minutes. Everyone gets assignments after meetings, so we all know what we're supposed to do before we come back together, which is nice, because everybody gets a task. You got to guest worker, like everybody, grandma that might be like in the other room, doesn't really want to join the table, she'll get a task, and things like that. And then the fourth stage is the best stage. I mean, that's the hope stage. So we tell our families, you know, your kid's diagnosis is not probably going to go away. It might change, but if your kid is truly having, you know, a mental health diagnosis, they're not just going to get rid of it. Wraparound will not get rid of it, but we can help you plan for the next time something happens. So that's all the hope stage is about. It's about the 4 C's that you see there, and making sure not just the kid but the family feels successful in all of those C's. You know, a lot of times our families will say, wow, like I know how to handle this now. Like I know what to do in the ER, how to advocate for my kid, and things like that. And we celebrate with the graduation party. So you're probably thinking, what about kids that don't have Medicaid? And it's not really fair, they don't have access to this wonderful process. And it's true. There should be more access, but there is a way for kids who are very high risk and have really high needs that have private insurance to have access to us. It's through the SED waiver. So it's for severely emotionally disturbed children. And what it does is it allows for kids who do not have Medicaid, it allows for them to have a pathway where the state waives the family's income and looks at just the child. If the child meets that high criteria, which is a high threshold, I mean, they have to be at risk of out-of-home placement, hospitalized, you know, or scoring high on assessments. If they do, that child then has access to wraparound and all of the other Medicaid services for that whole year. Usually we're able to stabilize kids within a year. Sometimes it does take the two years of the waiver to fully stabilize and have a family in a good place. Some of the other services that we can provide with the waiver is art therapy, music, rec therapy, and overnight camp. So CMH has campership funds for our kids to go to camp. Waiver kids get an extra 3 camps a year overnight. That's all part of the waiver. So we have kids that take up on that once they're stable enough to go to camp, and they can go to 3 weeks of overnight camp, all covered by the waiver, which is like amazing for the kids to go to camp. So here's as I kind of move forward to the graduation parties. All of our kids, if they want one, we plan a graduation party. We tend to, you know, find out that sometimes less is more for some of our kids, but some of our kids want to go all out. One of the moms said here at a graduation party that they would not be here today without the help and wraparound services. So we get that a lot in the end. Some other quotes that families have said: Christina is amazing. She goes above and beyond for us every day. Couldn't ask for anyone better. She is the best. One child at a graduation said, this was by far the best day ever. Another child said at graduation that he was able to be positive and said that you can make or find your own happiness. We wouldn't be where we are without you and the wraparound program. Thank you for believing me when no one else did. I have accomplished so many things, it's hard to say which one is my favorite. We have never had someone show up for us so much. Wraparound gave us hope for our future, and I can sleep a little easier at night since wraparound has been in place. So how do we measure success other than those amazing quotes, which are my favorite way to measure success, but I know numbers are important. So we do scaling every month with our families on their goals and their treatment plans. The entire team gets to rate how they feel things are going, not just the child and family. We also do assessments, like the Campus and Practice, which will now be the Michigans, starting 10-1. We get direct feedback from our children and families. We do Happy or Not surveys, annual satisfaction surveys, and then MSU also partners with the state and wraparound and does, they're called family status reports, but it's their way of tracking success regarding the wraparound process, as well as they do 6 and 12-month surveys. So MSU has got a big partnership with the state with wraparound. So So I wanted to share really quick. Just a few examples because I think it's impactful for like our kids, because our kids are tough, especially when we first get them, and we have to really celebrate small successes with our families. It's not necessarily going to be the huge, like, cured situation. So these are just some of the areas of success that families have said. My son got off probation. My kid was back in school. My child graduated teacher's pet. She's never completed something from start to finish. My kid now has a 504 behavioral plan in school. I haven't gotten a call for over a week. My son made the honor roll. My daughter attended camps away from home. My daughter completed her trauma therapy and actually presented her trauma narrative to a safe person. My child participated in an extracurricular activity. My son was invited to his first friend birthday party. My child was able to attend our family vacation and get-togethers. We were able to move to a lower level of care. My son now can express himself and his feelings. I can actually go back to work now because my kid is in school and they're not calling me every day. My daughter was finally able to be adopted. I'm able to replace the holes in my walls now without fear of destruction. There's less days and less trips to the ER. My daughter is now not scared to sleep at night and will stay in their own room. My child has now become an example and role model in class. My child has an IEP now at school and getting the support that he needs. My son joined Cub Scouts. I found a medication that actually works. I'm allowed to shave my legs now without my mom collecting the razor. I have a job. I can volunteer. I graduated high school. My sibling feels safe now driving in the car with me. And my siblings and I were able to stay together. So those are some of like the literal everyday progress that we get to see with our kids in here. We get to be part of adoptions. So there's definitely the side in the beginning where we're at the ER with our families, but then the other side where like mom is able to go back to work, mom can read a book, mom can pay attention to the younger daughter because the older daughter now doesn't need as much care. I did include some graphs. So this is from the Red Cap system from MSU, and it just kind of shows the initial CAPA score on average in Macomb County and then versus the state. So we're getting kids on average at like a 130 CAPAS. So what that means is that they have elevated risks in multiple areas of their life. And then they're exiting at a 79. And typically our kids don't exit to meal services. Some do, but typically they're going to probably go to an outpatient therapy and psych management, typically. But so this is decrease of 61% improvement, which was better than the state average. So that's amazing, which was 59%. And then the other graph is just the average time that we have a kiddo. So in RAP, we average about 12 months, regardless of their funding. So regardless if they're waiver, or regardless if they're Medicaid families that come to work with us. So about 12 months. And I would say that's a little bit skewed. I would say most families stay with us for 15 to 18 months. The reason it's 12 months is because a lot of foster kids will be removed or moved placements right when we get them early on. So we don't really get to do the full wraparound process to no one's fault, but just placements change a lot. So we do have a community team. So kind of like this, like they oversee the community team aspect of wraparound. Because wraparound kids are multi-system involved, the systems meet. So we meet monthly, somebody from DHHS, MISD, the juvenile court, Live Right, which is a substance abuse agency in Roseville, and we all meet and we talk about barriers and systems, creative ways to approach our kids. If we feel like a family's really burnt out in the system, how can we rebuild those relationships? Because there's always like, one of the three systems that like the family's angry at, whether it's DHS, juvenile court, or CMH. So we have to navigate those relationships to help the families. So here is some pictures of just different things we do in wraparound and at Children's in general that I wanted to share. The one picture is at Flourishing Life, one of our main OT providers for our SED kids. They do really fabulous work out in St. Clair Shores. And then teacher's pet, I just wanted to highlight. Again, most of our kids are not going to do well in traditional therapy. And teacher's pet is a partnership that CMH and Agnes Ward really supports and spearheads for us. So teacher's pet is amazing. It is an organization that takes animals, dogs specifically, that need to be trained. Not aggressive, not food aggressive, but ones that are just a little bit wild and need like basic obedience skills. And they pair the dogs with our kids. And then they go through a 10-week cohort, learning about dogs, learning about behavior, learning about attachment, trust, all the things that they struggle with in their life, they're working with the dogs on. And then they get to do a huge graduation where they present their dog, they get to show the dog, and it's really cool because it's sometimes the first time a parent has seen their kid like in a positive light, and so they're like taking pictures and videos, and it's pretty special because, and then the dog's being adopted, and it's wonderful. So it is a therapeutic program, though. Amy Johnson is who is the CEO or of the program, and it is a therapeutic program. So my team here at CMH is me. No, I'm just kidding. I'm the clinical supervisor, but I do have 8 coordinators, wraparound coordinators. They work with about 10 to 12 families at a time, and some of my wrap coordinators are cross-trained. So they, some of them do family training with PMTO, and then some also do some strengths and strategies with kids who are assessed for possibility of having FASD, fetal alcohol syndrome. So my team is very versatile. They all have like really amazing different job histories and training. So we have a really great team. We are the only, well, we were the only provider in Macomb County for wraparound and S&D labor, which is, I mean, we did a great job. We held it down, but it was, lonely for a while. And finally, TTI, which is a provider in Macomb County, has been enrolled with the state and with CMH and contracted to provide wraparound and labor. So we are super excited to have them as a partner, so we can serve more children and more families in Macomb. When I made this PowerPoint, we had about 54 kids currently in wraparound. The number does fluctuate just due to, again, foster kids moving, which is unfortunately quite common. This is our annual conference I have a picture of. We were trained by the state in the wraparound process. We have to be certified. It's a promising practice. It's not an evidence-based practice yet, but wraparound is all over the U.S. and in other countries and producing great outcomes. And that was it. I don't know if anyone has any questions about what we do at Children's or about wraparound specifically, but we house all of the specialty services at Children's. So any kind of specialty training or service that a kid might need, we have at Children's. You could always come visit if you want. Thursday nights are the most fun. But does anyone have any questions?
It just sounds like a wonderful program, and I think you're doing a wonderful job. So I'd like to congratulate you and all of your team. It sounds like you're doing a great job, and it sounds like you're doing really a great service to all of the people that you serve. So I'd like to say thank you very much.
Thank you, Donna. Yeah, it's wonderful. It is. Being in families' homes and working with them in their home, it makes such a difference to be able to see them and be with them in their environment. So that's also one of the things I love about wraparound. It's home and community based.
Yeah, I worked with a lot of probably the same kind of adolescents at Neil Reed and at Rockville.
Yeah.
So
I
loved it.
Half of our kids in wraparound are at the ISD schools.
Yeah, I absolutely loved working with them, and I know you're really doing such a great service. Thank you so much.
Thank you, Donna.
Anyone else?
I just want to make sure to say thank you.
Yes, thank you guys so much, and thank you for all you do too, all of the, background stuff, because it's a lot.
We might take you up on your offer to come and visit. So.
Come visit, yes. Thursday nights are clinic nights, so we're open late, and a lot of our kids are there at that time, so that's why I say it's a really great time to come on over.
This is for Kinlan, you said?
What was that?
Is it for Kinlan building, or?
Oh, yeah, the Verpillion, yep.
Thank you.
Well, thank you guys. Have a good night.
Thank you.
Thank you.
resolutions? We don't have any resolutions. Other agenda items? Item 8A, new provider directory presentation.
Hi.
This is going to do amazing speed with like a follow-up link.
Yeah.
Huh?
So I didn't know where we were going to have AV. It seemed like Liz didn't know either. So I'm going to wing this. We launched a new provider directory on the website. We found the new community resources and provider directory menu. I'd be happy to return at some point and do a guided tour, hopefully earlier in the meeting. As always, feel free to reach out once you get the opportunity to check that out, and we will send a link if one hasn't done already, if it's not in the board packet, to actually go to that on the website. It is live and has been for a few months now. I also presented this to the CAC already, and I'm kind of, making the rounds. And so some of the things that you'll notice is that was more or less like a Word document for years, not very interactive. This is a fully interactive map on it where you can get driving directions, walking directions, transit directions, and search for providers by the services that they provide, look for things within a certain amount of mileage within your zip code, all sorts of different ways of kind of breaking down that list of providers. And hopefully, if you're on, this kind of ties into another feature that we launched. It's been like 2 or 3 years now, I think, the chat on the website, along with, calling our customer service department. You could direct somebody to that while you're on the phone, and they could kind of get an idea of, here are the kind of services that you're able to get, and these are the kind of locations of the providers and stuff. So it is really meant to be kind of a guided tool and a supplement to some of the things that you're able to kind of go through with the person served. Along with that, we also launched multiple languages on the site, so you can get interactive translation into all the languages that we translate our member handbook already, and a couple of additional
languages and then some, like the ones we've identified in Macomb County are the most prevalent, and then there's other options also.
Yeah, so again, we'll send out a link directing you to that. That's something that I worked on in collaboration with our network operations department. They kind of provided the data, and I did the technical work on it. So reach out if you do check it out and you have any suggestions. We continue to kind of make improvements, add additional data to it. And it at least appears to this point that it does also satisfy a bunch of audit requirements that we have for with HSAC for our provider directory. So it's a dual role on that as well. So any questions?
Thank you, Thomas. We'll take a look for the link. Send out. Does anyone have any questions? Vic?
You're going to send us the link, or there's a link?
I assume it'll either come from myself or Sandy.
Okay.
Yeah.
But for the average person who wants to get on it, they can get on it.
They can get on it from the community resources menu on our website.
Okay.
Yeah. I believe it's the second.
And again, I hope we're coordinating with PR people, because people don't know these things. So
Great. That's why Thomas is doing the rounds first. So we shared with the CAC because we wanted to give it, like, even though it's launched, we've got some good feedback about, hey, what can it do this? Can it do that? So before we did the PR part of it, we did want to make sure that if there's any improvements we can make. And then secondly, in the pocket guide, to your point, the second page when you open it is going to be a QR code and also the website sending you right to the provider directory. But again, we want to make sure it's
we wanted to make
the
sure
best
that
it can
from the
possibly be
CAC
for a
and the
couple
board
months.
and opportunity to kind of make its rounds and get any initial improvements, because there would have been something that we didn't identify in your testing that was like, oh, this just does not make sense. It's not going to work for the average person visiting this shit. The way that you described it. So, but yeah, again, if you do want a more personal guided tour or anything, feel free to reach out, or if you have any questions, feel free to reach out.
And I know your brain is basically mine is overwhelmed, but I just want to make sure everybody knows that Thomas and the preparations did a ton of work on this for a ton of period of time, and it really is impressive. So when we send you the link, if you could just take a couple minutes to play with it yourself. So imagine now you can be talking to somebody and you're like, oh, you need something? Okay, let me help you. Like any average person can find exactly what they need and where they need to and how to get to it. And so I just want to make sure to acknowledge the hard work and amazing work that they did.
Yeah, and if I do come back and present on this, there is a forthcoming thing that we're going to be adding to the chat and the website where you can actually co-browse with somebody. So somebody in customer service would be able to, like, they could be on the phone with somebody, direct them to the chat, and then they would be able to see where they're at on the website or lead them to a part of the website. And so if they wanted to take them into the provider directory when they're on the phone with them, they would actually be able to get them to that place in the provider directory and be like, here's all the things that you need to know. Oh, you need, it has a bunch of ADA requirements in it, or ADA accommodations. So you would be able to see, oh, is it wheelchair accessible? Is it X, Y, and Z? That sort of thing. So, yeah, we intend on it being hopefully a very useful tool, if not now, going forward for
Thomas, thank you for all your hard work on this.
Yeah.
Looking forward to seeing the link.
Yeah, thank you.
Any comments, questions? Thank you, Thomas.
Yep.
Item 8B, update on possible CMH West location.
TJ is going to give a high level, very high level. Yeah. Like very high level update only, and I'm just trying to bring it along. I really just
5 minutes.
Okay.
5 minutes.
Great.
We're going, TJ.
2 weeks ago, I presented with 2 leases with regards to the relocation from the current West program to 2 different locations, and that was approved at that time to move to full board for approval. Just, I know some people weren't here and somewhere, so I just wanted to bring everybody up to where we are. I have that correct? I wanted to first say what the picture that Lisa painted was so eloquently delivered for what our staff do for our clients. What I have to think about is the safety of our staff. And this whole endeavor was really centered around safety. That's what drove this entire project. So I would like to just recap some of the points that I made 2 weeks ago, and there's a couple more data points that I'll point out. We heard the calls for safety previously, registered concerns from all corners of our team as it related to current events, and that is the single greatest motivating factor of this proposed move. Along with that, there are some other significant pros that I would like to briefly highlight. Additional space, the space being presented is being traded for currently unusable garage storage space, which is significant at the current West location. That serves little to no purpose, and that new space will translate into more open yet secure working environment. It will allow for the expansion of programs and staff much more efficiently, and it will allow for flexing of programs, better oversight, and in some cases accountability. The current configuration of West is represented by an aging industrial building that taxes both our bottom line with repairs, but also is simply not representative of what MCCMH is or is to become. Both new facilities offer a fresh approach to client traffic, ease of mobility, and an opportunity for front-facing staff to better accept, greet, and direct and offer services to our clients. Reconfiguration of office space would include new, used furniture, which is also scheduled as part of this relocation. Many of our staff have been working at old equipment for quite some time. Technology, the last piece, technology is fast working its way into our system via telehealth, call queues, and the like. And this space and this concept that we're laying out in these 2 buildings would greatly improve that capacity and capability. Last, there was some concern over bus. We have collected bus data and how many people got off of the bus. The average was 3 per day. Lowest was 0 and the highest was 5. And that data, just to give you an idea of how many people are coming in via bus. I don't know if that eases some concerns,
or it elevates concerns, but I think that data was key. There has been a lot of questions on the backside of this about staff being required to offer client services in their workspace, and that is not the case. This, like I said, is all around safety. There are special rooms that services would be conducted, and then staff return to their workspace. That is really the amount, the full extent of what additional that I have to provide. I still believe in this. I believe that safety is paramount in today's times, and moving forward, I think that whatever we do, we're going to have to do that, whether we stay. It's going to be a very costly endeavor to make that happen. Or if we move, I think that it will be easier, but I think safety is something that we're going to have to address in all of our facilities, and it will just be much easier, and we can accomplish a lot more in being able to move this forward. So I'll take any questions, but that's really it.
Does anyone have any questions? Lori?
Yeah, I'm glad to know. Thank you very much for having gotten a report already, for checking on the number of people that do use public transportation. I appreciate that. It's not as high as I assumed it was. And I guess my other question is, are there any other of our clinics that are on a bus line? Because I think that's important for us to know, and how they transport. Groesbeck is not on a bus line, so, and I know that was a huge concern for a lot of people, but again, I assume the numbers were much higher than that.
The east location, Lori, is on Harper, and that is a bus line.
Okay.
There is not a bus stop that is within a close proximity, but it's a short walk, much like this walk would be from the location of 15. There is not a bus line on Hall Road. There is quite a few bus lines within Macomb County that are reliable, but the trouble has been finding a location that suits community mental health's needs with parking and the amount of staff. We simply cannot find that space. We're very, very, very limited into what's available. And this property on Mountain Road, we timed it was a 7-minute walk. It was the best that we could find closest to a bus line.
And the other question I wanted to ask was, did you review that there is a sidewalk going from Mound into?
I went for a walk.
Okay, so there is a sidewalk. So
Yes.
I look at a screen GPS thing that brings me up there where there was no
There is
sidewalk.
a walk. There is a sidewalk
Okay.
the entire way.
All right, that's what I wanted to know. Thank you.
Nick?
Some of us, including you, have been trying to work with SMART to get some alternatives, at least consideration for alternatives. Part of the problem with the bus line issue is that people that would have trouble walking from the bus stop to the Mountain Road Center probably already have problems walking from their home to the nearest bus stop to get on the bus in the first place. I think that's what has reduced the number of people that actually use the bus. There's an overall transit problem in the state, but clearly in this county, in this region, and it's not new. It's been around for 40 years. I know Phil has reached out, I've reached out, and you've reached out. Has SMART made any suggestions of possible ways to help transport our members? The Connector program is one, it's not ideal, but it's at least one option, or other options that they may suggest, or have we just not heard anything?
There is a service they call the Flex Route, and that is a call to order. So you can call and order that bus, and it will do door-to-door delivery within a certain amount of distance of a bus stop. So it has to be within a certain distance. But that is the standard response that I got from them, but I have also learned from other people that it's not a very reliable system.
Well, it's not available in the Mound Road area. It might be available in the Hall Road area, and it is problematic. What about the connectors? The connector is a small band type thing that goes from home to...
And TJ, can I jump in? Only because I think, Nick, your questions are very on point. In fact, I think a lot of people's questions are on point. Phil and I have been talking, and Phil, you can jump in about the smart, but how folks they want to approach this a little bit differently. And I was going to do this in the next presentation, but I think it matches this. Essentially, we have to better understand the problem, right? Like when we said 3 to 4, we're like, okay, that's interesting information. What does that mean? Also, to Lori's point, all of our locations have this problem, right? This is not a, are we going to be this new float location, yes or no problem. So one of the things that we're going to start doing is start first with how big is the problem and what are the current solutions that exist, and then therefore what's the gap between those. So I don't want to do it tonight because I really want you to be fresh and paying attention, but I'm going to give you an example. This is the list of transportation services beginning October 1st for those who are on the Medicaid health plan. Tonight, I'm not going to overwhelm you with what that means, but imagine we are going to start educating on you. When we talk about this population, how many of those people do we serve? How many need transportation? And what are the current existing solutions for that population? And then start asking, who do we need to partner with? Who do we need to pester? Who do we need to whatever to better address the gap? But I don't think we as a group have the needed information to best come up with a solution, because calling smart and advocating with them is great, but they're not going to be able to resolve the big problem. So I guess I just want to propose a more strategic review of what the problem is, where the gaps are, and again, what already exists. Because just for this population alone, there are potential solutions, and then we have to go, do they actually work?
I look forward to that presentation, but I think it is important to look at this problem not just from the Mound Road facility, but from all of the areas, because transit is a problem. We know it's a problem. It really wasn't on the top of our agenda because there are transit folks that are supposed to have this at the top of their agenda. Quite frankly, very disappointed with the responses we've gotten from our transit folks. We continue to do that, try to get some responses from them, but we may have to take on more of it than we should have to take on.
But to your point, we don't want to take on more that we don't have to, so what is already there?
Yeah.
So I don't want to speak for Bill, and if this is not true, Bill, you know, is we're kind of hoping that we can work through this and maybe make this one of our initiatives, not our priorities, but our initiative maybe goals in 2025, and really dive into this, because Nick, we can't use the transportation solution, right? We have to better understand it, how to maximize it, and then help others become the solution.
Thank you, Nick. Phil?
If I might just to piggyback real quick, and SMART is not going to be the end-all be-all. SMART may not always be there. SMART has been on the precipice of being cut and not approved a couple times now here in Macomb. So we completely rely on them as the only option for our folks, and that proposal goes down, we're in a tough spot. So I did talk briefly with Tracy, and the deep dive is fascinating, and I'm excited to share that information with all of you when we do have fresh brains in our kids, because there are several, I think there could be several options for the number of folks that we have utilizing that system at all of our locations.
Yes. And it's a lack of knowledge. We hear lack of knowledge on all of our, it's not just the people sitting at the table, but we want to educate the community and educate the staff. And
Okay. Thank you, DJ. Does anyone else have any other questions? But it's been a long night.
Lori, feel free to call me. Feel free to call me if anyone has any questions.
Be careful. Thank you.
It's been a long night. Sorry. Give me your name.
My CEO update.
that was my update. I respect your brains need to be fresh, but I won't challenge you
Tracy. Next board meeting is September 25th, 2024, and it's right here on the 9th floor. Number 9, provider comments. Is there anyone from the provider comments looking to speak? No. Is there anyone, item 10, hearing from the public. Is there anyone from the public looking to speak? No. Is there a motion for adjournment? All in favor say aye. Aye. We are adjourned.